Intravesical OnabotulinumtoxinA, a wonderful tool, but I'll be underestimating urinary retention. A retrospective review from a single urological specialist in Australia looking towards predictive factors. We have no financial affiliations to disclose. Intravesical OnabotulinumtoxinA is becoming a well-used tool for management of overactive Detrusor refractory to medical management, with efficacy well documented. Allergan report a rate of urinary retention requiring intermittent catheterization at approximately 6% for patients post-treatment of idiopathic Detrusor overactivity. Despite this classically reported risk, other randomized controlled trials report rates of intermittent catheterization between 4.3 to 43%. This study aims to review the experience of a specialist urological surgeon to see if current quoted rates of urinary retention are in line with prior experiences, as well as to identify preoperative predictors for retention to help guide future consent and patient management. A retrospective review of a single Australian urologist was completed. All female patients who underwent intravesical OnabotulinumtoxinA for management of idiopathic Detrusor overactivity were included. Patient data was collected from February 2016 to March of 2021. Patients were not included if they did not have a complete preoperative urodynamic assessment available for analysis, or if a patient was lost to follow-up. Patient demographics, significant past medical history, urodynamic assessment, and post-operative post-void residual was recorded. The two primary outcomes for post-void residual posed 100 units of intravesical OnabotulinumtoxinA, and the other was identifying rate of intermittent catheterization within this cohort. Secondary outcomes looked at predictive factors for elevated post-voids post-operatively. Data collection is ongoing, and we publish interim results. Post-void residuals were measured between 2 to 4 weeks post-operatively. As our study was retrospective, initiation of intermittent catheterization for our patients was clinician-based for best clinical outcome for our patients. Initiation of intermittent catheterization was dependent upon post-void residual and clinical concern for poor effective bladder emptying, and not just based on a number. For example, if a surgeon was convinced voiding volumes were significant in relation to PVR, even if the PVR was elevated, intermittent catheterization was withheld. Conversely, a low PVR in a patient only completing small volume voids could have intermittent catheterization commenced. This is in direct contrast to prior Allergan data, which determined need of intermittent catheterization on PVR, where depending on the patient's symptoms, the investigator could initiate intermittent catheterization at a PVR volume between 200 and 350 mL. However, all patients with a PVR above 350 mL automatically initiated intermittent catheterization, regardless of patient symptoms or significant voiding volume. Our results showed 77 females who qualified for inclusion, with a mean age of 70 years, ranging from 18 to 95 years. The average post-void residual was 106 mL, ranging from 0 mL to over a litre. 54 or 70% of our patients were deemed clinically safe to avoid intermittent catheterization, with a range from 0 mL up to 480 mL. 23 or 30% of our patients experienced urinary retention, with clinical concern for incomplete bladder emptying, resulting in initiation of intermittent catheterization. Preoperative urine MCS, which was positive and pre-treated, as well as a previous history of mid-urethral sling surgery, were more common in our intermittent catheterization cohort. We have identified a higher than expected rate of requirement of intermittent catheterization, with 30% within our cohort compared to quoted 6% in Allergan material. This is despite our surgical experience having more tolerance for comparatively elevated post-void residuals. Within our cohort, age and preoperative PVR did not appear to be a predictive factor. We acknowledge limitations include a single surgeon cohort, but believe it is one of the largest comparative data sets looking at rates of intermittent catheterization for females with idiopathic Detrusor overactivity. Simple statistics were used for comparative analysis, but we hope to use multivariate logistic regression to assess statistical significance of predictive factors. These results are in line with other internationally recognized studies with similar rates of intermittent catheterization post 100 units of OnabotulinumtoxinA, which are up to 6 times those reported from Allergan. We suggest further investigation looking into max flow and absence of obstruction on urodynamics, which may be protective factors for patients wishing to have an accurate risk profile preoperatively. Future studies will look to a wider sample of urologists in our region to gain a larger patient sample to attempt to create a predictive tool for post-operative retention risk, as well as a consideration of a prospective trial to see if volume of aliquot administration has an impact on retention rates. Of course, we welcome any further questions or interests in discussing further investigations.